welcome to our latest episode of Candid Conversations, where we discuss everything related to neurodevelopmental conditions. So, I'm Sujeet Jaydeokar. I'm consultant psychiatrist in intellectual disability psychiatry, and I'm going to be your host for today. And it's my pleasure. I'm here joined by Dr. Ian Horn. Ian, we go quite far back. So you are now treasurer for all College of Psychiatrists. Is that correct?
That's right.
Uh, and you have been examiner as well in the past. So I know from our working together days when you were the training program director and I was deputy training program director. So these are my London days, and you always been quite interested on the training, especially the psychiatry, medical education, those sort of things, isn't it?
Yeah, that's right.
Uh,
Yeah.
yeah, so I thought today we can actually discuss training related issues, especially when it comes to intellectual disability psychiatry. And we don't just have to maybe focus on psychiatrist or medical training and perhaps look at it from broader perspective um, um, as well. Um, I was kind of reflecting on our previous conversations, etc., and kind of was wondering about what constitutes as a good training experience for. Let's start with our medical workforce or like the higher trainees in intellectual disability psychiatry. What are your thoughts?
Oh, right, in psychiatry, yes. I think it's really important that they see really good examples of good practice. I think they need a really good mentor and a good trainer. That makes, I think, such a difference. But also the training environment and train in places where there are, good service models, where they're implementing best practice. I think that goes a long, long way.
Yeah, I mean, I think for us, it's quite regularized, isn't it? I mean, I'm not sure whether that's the same things apply to wider training. So when we um, look at some of our multidisciplinary colleagues, do you know from your experience, do they have similar approach to what we have? Um,
So I think obviously in nursing, there's a particular nursing program for nurses working with people with learning disability, but that is not, I don't think, the case with other MDT professions and with social workers. But as you say, in psychiatry, we have a particular specialism for working with people with learning disability. So that is definitely a
yeah.
difference.
And we get quite regularized, isn't it? I think the placements, everything has to be GMC approved places for training as well, and college approval process. So that's quite stringent. I mean, I think from my experience, the placement, having a good placement is so important. So I remember when I was training, I was quite fortunate to be with likes of Adrian Regan and Jack Piacho. Bless his soul. That are huge influence on kind of my thinking and how I looked at uh, not just psychiatry, intellectual disability psychiatry, but in general, actually, society and the role within society, especially when it comes to disability and ethics and all those side of things, isn't it? Really fortunate in that respect that I had such a good training experience on that front. But I mean, the things do change. I mean, our training days were quite different, and I think the needs are quite different now, isn't it? I think how do we ensure training is fit for purpose, especially in light of the 10-year plan and things that are moving in different directions?
Yeah, it's interesting reading the 10-year plan, isn't it? Because some of the things they talk about are things that we have been doing for many, many years, isn't it? And made a lot of progress with. So particularly, for example, providing services in the community, but also I think prevention. I think prevention has come a long way in the last 10, 20 years, especially with all the work about access to health that arose out of various scandals, as we know, with people with learning disability very badly
Yeah,
treated in hospital.
yeah,
And that that whole prevention and accessing health much easier goes a long way. And I think one of the things we really need to instill in training in all the disciplines is this advocacy for people with learning disability and helping them get support from other services.
Yeah, I think the advocacy will be quite important, isn't it? In a way, actually, learning disability psychiatry, intellectual disability psychiatry, we lead the way in terms of person-centered care, access, adapting access or adaptability of our services to improve access. We are quite good at that. We are quite
Yeah.
good at adapting communication. Um, something for other probably specialists to take from us,
Yeah.
isn't it?
And this whole idea of personalization, as it's called now, but meeting individual needs and doing that. We have been doing that for a long time. That's not to say there isn't more to do, but yeah, but the role is a bit changing to say, like, holding other services to account, to say, actually you need to make adjustments for this individual.
Yeah. You're right. It's not just what we are doing, it's how we influence the wider system in that respect, especially with all this neighborhood care and those sort of things. That's going to be quite important, isn't it? Because the expectation is that somehow neighborhood care is going to solve all the problems of access. But when it comes to people with intellectual disability and all that, we do need to make sure we are able to influence those wider systems.
I think in learning disability, I think we're used to this concept of intersectionality, so that people with disability are discriminated against, but also they're part of other groups that may be experiencing discrimination. So I'm hoping with this general push towards the more neighborhood model, there'll be more understanding of local communities and how to make services accessible. I worked for a long time in Tower Hamlets, where there's a big
Yes,
Muslim
yes,
population,
absolutely. Yeah,
and they had particular requirements about
yeah,
day
yeah.
services, for example, and how different people of different genders were supported, and if that wasn't in place, people wouldn't access services. So it's just an illustration
Yeah.
of how
Yeah.
important it can be.
Yeah, no, absolutely. I remember actually, and I remember you talking about it in the past as well in terms of improving that access in culturally sensitive way. It's isn't it? It's what we do. I mean, I think the two you mentioned intersectionality, and it's very important. Look at the ladder report and all that, and the sort of the health inequalities gap when it comes to Black minority ethnic compared to rest is quite stark in that sense. Women with intellectual disability, and a lot of the time we don't look at it that from that perspective. And I was just thinking about one of my colleague is doing a project around menopause and women with intellectual disability. So we do need to keep some of those different aspects into account. We are quite heterogeneous population. But the two things that come in mind, that the prevention agenda, because traditionally we focus on treatment side of it, isn't it? And public health and prevention to some extent goes into the public health departments. We don't always consciously think about it. And then second part is influencing. I think that's kind of something that you alluded to, that we need to make sure but that the future workforce kind of play that key part in influencing
Yes.
wider systems.
I mean, I think on prevention, all the health documents have said this for many years. We need to focus on prevention, but actually, the delivery of that, in my view, has been pretty poor. And I think the good thing about working with people with learning disability in modern services is that we have this holistic model of care, and this idea that people should lead a happy life and have,
Yeah,
their needs met. And I think if you do that, you're able to do this health promotion, for example, access to exercise, healthy diet. These, obviously, they're quite basic things, but certainly in our service, we still struggle with that implementation, even with these people that have all this support, and that's something we're really
yeah.
focusing on, actually.
Yes, no, absolutely. And I think kind of health promotion is quite a big thing, isn't it, in learning, community learning, disability services. And you're right. I think we always talked, even medical student, as medical students, prevention was always part of the curriculum and agenda. It's just actually when it comes to now being part of service delivery, it focuses on more the acute side of things rather than the preventative side of things. And I think perhaps this is what we need to emphasize more and more in terms of the future workforce, that while idea is there, how do we translate it into practice, and how we actually do that, and perhaps maybe that's something we do need to uh, think about it more. Implementation of it, we need to think about it more. You were very good with co-production and co-delivery. I remember that from London days. Even the medical school and training, you got people with working with Angela and all that at UCL. Wasn't like
Yeah, and as we also at St
involving
George's,
the examination, medical student examination.
yeah, we've involved people with intellectual disability in the postgraduate clinical exam for psychiatrists, but also yeah, also with medical students at St George's, and I think that's really really important in training, that we use experts by experience as part of the teaching faculty. And it is, because this is really good modeling, in my view. It's showing people with intellectual disability in a really positive and valued role. And of course, they bring insights. And I have to say, my experience of it in teaching is that the learners really, really value it. And for those sort of reasons, just getting that perspective. So, yeah, I'm definitely very keen on that. But I'm also keen on, and I think what people need to learn as part of training is the importance of that co-production. For example, in service development, we had a
Yes.
very good example of this recently with the whole STOMP agenda, which is about reducing medication, principally for behaviors that challenge. And we had sort of all this slightly top-down guidance foisted on us. And then when we were discussing it as a team, we realized, well, really, we should ask the people we're talking about what they think about medication and what their carers think and what services think as well, which is what we've done. And of course, it's probably not that surprising, that's resulted in us developing a much more holistic service, and actually one that isn't so focused on medication. Because if you want to reduce medication, people need to be properly supported. So, that for me, that's a really good example of the power of co-production.
Yeah. Yes, absolutely. I think I'm quite passionate about that side of things. I mean, as you know, I'm sort of like myself a parent carer as well as a professional, so see both side of things, and I do see the importance and the difference it makes. And I'm trying to get the newer generation to think about it in terms of the service development, delivery, research, and how to be do the research in a co-produced way. And for example, we are doing something now where people with intellectual disability are co-researchers. In fact, they are doing qualitative interviews of participants. So it's really fruitful exercise, and the insights they bring are really valuable. Uh, and you know,
Yeah,
so
I completely agree. Although I think the most important thing with co-production research is asking the people with intellectual disability and their carers what we should research in the first place.
yes, I'm glad you said that actually. And one of the things which we are very proud through Candid is that we organized some stakeholder events, and we started by asking a question: what are the areas you think are important we should be doing research on? And as a follow-up event, we did a lot of small group discussions with the help of them, where we actually um, co-produced research questions based on the areas they have identified. It makes it very, very relevant. It becomes quite uh, clinically led and co-produced projects, research, evaluations, ideas for innovation. So yes, starting with a blank sheet and asking them the question. Perhaps we need to do that with the training as well. uh, um, Asking kind of what is it important that we
Mm.
should be teaching tomorrow's workforce from their point of view based on their experiences,
Yes. Yeah.
etc. So yes, absolutely, completely agree. Do you kind of see any challenges coming our way with technology developments, AI? Is that something we need to think about from training point of view, or
Well,
just go with the flow?
absolutely it is. Absolutely. And we're, with the sort of implementation of AI over the last few years, it's really thrown up some issues. And it's certainly a skill set, isn't it? How to use these AI tools and what faith to put in them and what not, what not to trust them with. And so on. So that although they're very powerful tools, and actually we've used it recently for
Yes.
qualitative research, you basically need to take things with a pinch of salt. Uh, I mean, the other big thing it's talking about technology is people with intellectual disability using technology, because the whole health delivery is moving towards this. So, do people have the skills, to use apps to book appointments, and so on? And yeah, do they have those skills? And actually, are the apps modified in a way that they're accessible for people with intellectual disability? So, there's so many aspects to think about. I suppose that
That's where the co-production is important, isn't it? It's
yes,
rather than
yeah.
implementing it, it's working with them and finding a solution. Absolutely. I was just reflecting on what you said earlier. We always had a critical appraisal training.
Mm.
Looking at the evidence-based critically, and we almost need that for the AI as well, because it hallucinates so much in a way when you ask certain questions. So it just needs to be really careful about using these things as an
Yeah.
efficiency tool, maybe, but for everything else, we need to be really careful,
Yes.
isn't it? Absolutely. Absolutely. But exciting. A lot of things happening. A lot of new development. It's always challenging, isn't it? In those sense, training needs to adapt, keep pace with what is happening in the world. Can't be static in itself.
Yes, but
But
we'd get bored if everything was the same,
absolutely,
wouldn't we? And actually,
absolutely.
one thing I do think about training is these whole skills about project management, change management, how we do that. And I think certainly in medical training, it's relatively poor on all those sort of skills. And these are the skills
Yeah,
we need to
yeah,
bring to services, I think.
yeah. Just that reminded me, more and more, especially in the research world, it gets used as the implementation science and logic model for research. Or logic model for implementation research is one of those frameworks. We do quite a lot in terms of improvement as training as well, or audits, quality improvement project, maybe a research, etc. But bringing implementation science in training will be quite useful, because I think it is about translating the evidence base into practice. And there are lots of framework. There are frameworks for public health implementation side. There are frameworks for health intervention implementation, complex system interventions, etc., etc. So again, that's an area maybe we should be thinking about for future workforce implementation science, and bring that into day-to-day practice. Uh, yeah,
Yes,
that will be quite
absolutely.
interesting.
Yeah.
Right. Ian, it's been lovely to see you. We don't get to kind of see each other that often, but I think this was great. I've seen you now a couple of times at conferences and all that. Candid is in the northwest. That's your not very far from.
That's exactly where I was born, in the Northwest. Yes,
Yes, absolutely.
and
And your
I
school
have a
is
lot of
also not
friends
very
in
far from
Cheshire.
us.
So yeah,
You went to Cheadle, isn't it?
I grew up in Cheadle. That's
Yes.
right.
Yeah. So perhaps next time you can come and join us at our Candid conference. I know you are not able to join us this time around. So
Well, no, I'd
we
love to
have,
come. I think it's been so impressive the way you've developed Candid. I think it's really good for the
yeah,
future.
like I said, I learned things in London, and kind of like brought some of that learning here, and some of that learning was with my colleagues here. So it has been fantastic actually journey, and fantastic set of people working with us here on Candid. So to come and see us at the
Yeah,
probably at
we're
the 8th annual
delighted.
conference.
Yeah.
But yes, I'll catch up with you soon.
All
Thank you
right.
very much. Yeah.
Take care. Bye bye.
Yes. Bye.